Good morning, everyone. It's a great pleasure for me to present on behalf of co-authors our work on genomic analysis of 733 HER2-positive breast cancers, identifying recurrent pathway alteration associated with HER2 resistance. I have no disclosure. HER2 is an oncogenic protein expressed on the surface of the breast cancer cells, activated by the formation of homodimers or heterodimers with the other receptor of ER family. And the proliferative effect mediated by HER2 is associated with its complex downstream signaling that mainly converge in MAP kinase pathway and PI3 kinase AKT pathway. And HER2 antibodies and HER2 tyrosine kinase inhibitors use many mechanisms of action resulting in antitumoral effect. One of these is blocking the downstream of HER2 cascade at different levels. And for years, the reactivation of PI3 kinase pathway has been considered the main player of HER2 signaling resistance, while MAPK pathway has been less investigated. In our work, we choose to focus specifically on these two key pathways and how they are involved in their two blockade escape. There is a significant amount of literature demonstrating that PIK3CA alteration confer a phenotype of resistance in breast cancer cells, as showed in this preclinical study of the Netherlands group. Cells carrying PIK3CA mutation or POP10 alteration in yellow, blue, and red, respectively, appear to be resistant when treated with trastuzumab. And the prognostic value of these alterations is pretty clear if we look at the Cleopatra-Kaplan-Meier curves stratified for PIK3CA status. Regardless the addition of pertuzumab, patients with PIK3CA mutant tumors represented by the continuous line had a worse outcome. And moving on the MAPK pathway, the literature data is limited. In our previous work evaluating the landscape of breast cancer, we noted that in hormone receptor negative HER2 positive tumors, the metastatic sample were enriched in NF1 alterations. And from this observation, we decided to look more closely on MAPK and PI3K alteration in our internal cohort, with the aim to investigate the significance of this alteration belonging to these two pathways. In this work, we included patients with HER2 amplified tumors per MSK impact who underwent prospective tumor sequencing between April 2014 and February 2021. We use an analytic pipeline that allows to integrate all clinical information with genomic data. And the hypothesis generated from this analysis has been eventually validated in lab. We sequenced overall 733 tumor samples from 664 patients with HER2-positive metastatic breast cancer, 385 samples from metastatic site, and 348 from primary tumors. PI3 kinase pathway alteration, as expected, were largely represented, with PIK3CA mutation detected in 33% of metastatic samples and 28 of the primary tumors. Interestingly, genes belonging to MAPK pathway have been found with genomic alteration. This pathway includes RBB2, EGFR, NF1, and all the genes included in the red box. And the most frequent alterations were found in NF1, 7% of metastatic sample and 4% in the primaries, and in HER2, the majority mutation, 7% in the metastatic sample and 3% in the primary. Overall, the MAPK alteration were more frequent in the metastatic samples compared to the primary tumors, 15.6% versus 9.8%. And this difference was statistically significant, suggesting that this alteration could have a role in acquired resistance. In this cohort, there was no positive association or mutual exclusivity noted between MAPK and PI3K pathways alterations. To evaluate the role of this alteration on patient outcome, we looked at a cohort of metastatic breast cancer patients homogeneously treated in first line with taxane-based chemotherapy, trastuzumab, and pertuzumab. All patients had sequenced pretreatment samples as per inclusion criteria. We identified 145 patients, and these are the patients' characteristics. The majority of patients presented with recurrent disease, only 18% with de novo metastatic. And the sequenced samples were from a metastatic site in 63% of cases, 37% from the primary tumor. And from a molecular standpoint, 80% of tumors were HER2 amplified per MSK impact. PIK3CA mutation were detected in 28% of cases and MAPK 15.8%. And this number were consistent with what I previously showed in the larger cohort. We evaluated progression-free survival stratified for PIK3CA mutations, RBB2 amplification per MSK impact, and MAPK alterations. As expected in our cohort, the median progression-free survival of PIK3CA mutant patient, represented by the green line, was significantly shorter than patients with PIK3CA wild-type tumors. And these curves are consistent with the curves of the Cleopatra trial. In addition, patients without RBB2 amplification per NGS, represented in blue, had a worse outcome on HP compared to patients with amplified tumors, suggesting that NGS is able to detect very precisely their HER2 cancer cells addiction. And moving on MAPK, we found that patients with alteration in MAPK pathway genes had a median progression-free survival of only 9.9 months, compared to the 21 months of the MAPK wild-type group. And this difference was statistically significant, with an hazard ratio of 2.03. In the multivariable analysis, after adjusting for PIK3CA mutations, RBB2 amplification per NGS, and sample type, metastatic versus primary, MAPK alteration remained associated with a worse PFS, with an hazard ratio of 2.2. And this finding suggests that the MAPK alteration are independently associated with a worse outcome. So far, I showed the MAPK alteration found on pretreatment samples are associated with a rapid progression on HP, and we did not have enough paired pre- and post-treatment samples to show the development of this alteration after treatment exposure. But here we want to show a representative case of our cohort. 38 years old patient with de novo metastatic HER2 positive breast cancer received THP with an initial response maintained for more than 2 years when she experienced a oligoprogression on a right axillary adenopathy. The sequencing of this single site of progression revealed a large NF1 intragenic inversion in the chromosome 17, as shown below, resulting in a loss of function of the protein. And this alteration was not found in the pretreatment sample. And for this reason, we believe that the acquired loss of NF1 was responsible for the clinical progression. The lab validation has been conducted in Chandler-Labati lab by a brilliant postdoc, Alison Smith and colleagues. And the full paper of this work has been published 3 weeks ago on Nature Communications. We found that HER2 positive breast cancer cell lines silenced for NF1, represented by the green and the pink lines, were resistant to the 3 currently approved HER-TKI, starting from the left, lapatinib, neratinib, and tucatinib. And when HER2-resistant cells silenced for NF1 were exposed to AKT inhibitor, cells continued to replicate, suggesting that PIK3CA pathway was not involved in the resistant mechanism induced by NF1. While when the same cell lines were treated with ERK or MEK inhibitors, the cell replication were inhibited. And similar results were obtained when MEK inhibitors are used to treat HER2-resistant cell lines carrying other MAPK alteration, such as HER2 mutations represented in green and KRAS represented in violet. These results were confirmed on xenograft model as well. Trametinib, a MEK inhibitor, was effective in reducing the tumor volume in NF1 silenced tumors only, violet line, compared to the resistant tumor NF1 proficient. And in a patient-derivated xenograft with NF1 loss, trametinib alone or in combination with trastuzumab was able to reduce the tumor growing. At this point, a question came in our mind. What about antibody-drug conjugate? Are they effective on these tumors carrying MAPK alterations? And the answer is yes. TDXD, as nicely showed in these curves, was effective in the inhibition of the replication of NF1 loss cells. And these effects may be related to the multiple mechanisms of action of these agents that are not limited to the blockade of HER2 signaling. PI3K mutation has been already recognized as a potentially target to treat HER2-resistant tumors, and 2 clinical trials with PI3K inhibitors are currently ongoing. The EPIC-B2 study, a phase 3 trial with alpelisib and HP in the maintenance phase, and another phase 1 study with copanlisib and HP again in first line. Our data showed that MAP kinase alteration is a new intriguing mechanism of resistant over HER2 signaling, potentially targetable. In conclusion, our work showed that for the very first time, genomic alteration of MAPK pathway genes are involved in the resistance to HP and HER2-TKI in metastatic HER2-positive breast cancer. This resistance could be possible acquired, as suggested by the enrichment in the advanced cancers versus primary. Not surprisingly, PIK3CA mutation and absence of BB2 amplification by NGS are associated with worse outcome on HP in our cohort. And HER2-resistant tumors that harbor MAPK pathway alteration seems to be sensitive to MEK and ERK inhibitors. And there is a urgent need of clinical trials to validate their use in patients with HER2-positive breast cancer in combination with entire 2 agents. This is my acknowledgement. This work would be not possible without all the colleagues and the association listed in this slide. In particular, I want to thank all the breast medicine translational program of MSK, Dr. Razavi and Chandralapati for the guidance, all the colleagues of the breast medicine service of MSK, all patients and their families. And thank you all for the attention. And I'm happy to take any question.